hypotension. Mentioned that we would be talking about it a little bit more today. So that's what we're going to do, talk about hypotension. I don't have anything to disclose for this. This is the bottom line. If you could just stop having hypertension, that would be great. So we tell all of our patients. I wanted to draw an analogy here for you. In the 1980s, we used to define tachycardia as over 100. That's what's in all the textbooks that we all learned in our training program. What we discovered in the 1980s was ischemic potential, myocardial ischemic potential, and found that many patients, it was a lower heart rate. And so we started thinking about heart rates being more like 20 to 25% of baseline and not just over 100 as being tachycardic. And so there's a parallel issue that we've now begun asking the question about blood pressure instead of heart rate. There's lots of things to think about blood pressure and perfusion. This is one of the grids that are out there that get you to think about things. These are mostly designed for emergency departments and that sort of a setting. We have patients, and you probably have patients of your own, that have blood pressures that prove this particular chart to be less than completely accurate. But the point is that there are a variety of symptoms and problems with hypotension. The second part is to ask the question, if we have the person in front of us and we're going to be managing them, what target blood pressure do we choose? And I tried to craft two patients that seem to have a lot of similarity, but I think most people in the room would agree that you likely need to have a different target of blood pressure for each of these two patients, despite age and many of the disease states that they have and drugs that they're on being highly similar. So what is the definition of hypotension that you might be able to use? Is it associated with a change in outcome? You heard a little bit from Dr. Faraday yesterday. How do you manage hypotension? And then if you manage it, does that actually change the outcome? So I know it sounds a little bit silly, but I think this is probably the best you're going to be able to do, is say that hypotension occurs when the blood pressure is lower than the desired blood pressure. And we'll talk about that a little bit more as we go forward. I think clinically, you see studies, some use an SBP, systolic blood pressure of less than 80 or less than 90. Some use a MAP of less than 60 or 55. Others do, similar to that tachycardia issue, we'll say reductions of 30% or greater from baseline. Does pre-existing high blood pressure make a difference as to what your target should be? And we'll talk very briefly about autoregulation, but your autoregulation curve is shifted. And so does that have implications for what blood pressure you might define in a particular patient? Notice how we're starting to get very patient-specific oriented, and so we're sort of pushing up against precision medicine now and the ability to customize the care and not just do everybody that's below 55 or above 80 or whatever you might choose as the threshold. The last thing that's important is an integration of time and amount of hypotension, and we'll cover some of the studies that have not looked at it specifically, but have some outcome data that helps us understand that there is a component of exposure volume, but there's also a component of all hypotension is bad. This is just to remind you of the autoregulation curve. This is to remind us to make sure and you'll understand when I get to the very end of this talk why I want to bring this up now so specifically, but the way the autoregulation curve shifts to the left or the right over time in patients. And again, I'll come back to that near the end. So is hypotension associated with altered outcome? And the answer to that is there are studies that have looked at the heart, they've looked at the kidney, there are studies that have looked at brain, stroke is an example, and there are others that have looked at mortality. And almost every one of the studies has shown that hypotension is associated with badness. This study you saw briefly yesterday from Dr. Faraday. The y-axis is disease-free survival. The important thing are the two middle curves. Remember, higher is better, more survival. And it actually turns out that hypotension is worse than severe coronary disease, which are what those two lines in the middle are. So hypotension is bad. Dr. Sessler looked at, in the POISE study, looked at when does hypotension occur and identified that hypotension, as you might expect, a lot of it is introp. There is some of it that's still significant amount that's later in the day on the day of surgery, so post-op day 0, and then hypotension that can occur all the way out to day 4. You might imagine that the hypotension on day 3 is very different than the etiologies of the hypertension that occur on day 1, but you'll see in a minute that the outcome is still impacted at about the same. So in that study, they looked at and you can see the definitions for intraoperative hypotension, post-op day 0 hypotension, or that 1 through 4 hypotension. You can see it doesn't matter which of those you use. The average relative effect on odds ratio is important clinically, and so hypotension is bad whether it occurs intra-op, immediately peri-op, or post-op. You also saw this graph, at least one of the two of these briefly yesterday from Dr. Faraday. The left axis is MINS, make sure it's on the same side as yours. So on the left, and the far one on the far side is AKI. And you can see that any amount of hypotension for any period of time has some association with a change in outcome that's to the worse. So if hypertension's bad, can I manage it in a way that would make a difference? And the first question becomes, again, we get back into that definition. So how do I individualize? How do I do precision med to help me try to sort this out? And the IMPRESS study tried to do just that. And the two groups in the IMPRESS study looked at individualizing that, so systolic blood pressure within 10% of the resting blood pressure, or just a standard management group where blood pressure would be treated if it was less than 80 or more than a 40% reduction from the patient's baseline. A little more of a classic sort of approach that's standardized. This is just showing you that they hit the target blood pressures and the difference that you might expect in those two groups. And so if you do as they suggest, or as we're sort of implying, that hypertension's bad, so individualizing care is better, would the outcome be improved? And you can see here that with the y-axis being organ dysfunction, individual treatment being better, there was less dysfunction, so a higher line, so the lower line is a better outcome. So individualizing treatment made more sense than just treating everybody with one definition of hypotension. There's more to discuss. So it doesn't appear that hypotension is good for you. It doesn't seem to matter what the exact definition is. All hypotension is bad. It doesn't seem to matter the exact duration. 10 minutes is worse than 1, but 1 is bad as well. It doesn't seem to matter if it's happening intra-op, post-op day 0, or the next 4 days. Those are all associated with bad outcome. But it does appear that individualizing care and thinking about how to customize it may be a tool that helps us. The next question becomes, if hypertension's bad and it's associated with organ problems, then could we predict who's going to become hypertensive before they do so that we can intervene and avoid hypertension as opposed to treat hypertension? And so that got several companies to look at this and create catheters and processes and algorithms to look at what's been called the hypertensive predictive index. And so again, if we can predict, can we mitigate? And you can see how it might be defined. One of the problems with these is that they historically have required art lines. Some of the companies that are making these are now looking at and or are publishing early information about the ability to look at a waveform from even a blood pressure cuff and trying to help us understand whether that would help us. What we know is that if you use a hypertensive predictive index and you intervene, then you tend to have slightly more hypertension in those patients. We don't really know what the ultimate effect of that is. And if you want to get into the controversy over hypertensive predictive index, I suggest you read the pro-con debate in the Journal of Cardiothoracic and Vascular Anesthesia. It's a very interesting read. But what do you want today? What you want to know today is if I use HPI, might that make a difference? And you can see that this particular study, that's a single center study, that the use of an AI, a machine learning process to create an early warning system with standard care resulted in less intraoperative hypotension. So they were able in this trial to have less hypotension by predicting who was about to be hypertensive and intervening. In this study, where they looked at it, they found that half of the alerts were not followed by treatment. presumably due to short warning time, complex algorithms, or clinicians simply ignoring and not believing the predictive index. So although the study showed no difference, the problem is that there was a lot of non-compliance with study protocol. So it's hard to know what to say about HPI. And Dr. Faraday mentioned a study that's about to be published. Until we see that study and know how aligned with the treatment strategies, did the patients actually get what they were supposed to get when they're supposed to get it, it's hard to know how to talk about that particular trial at the present time. But that may change our perspective. So if hypertension's bad, whether we can predict it or not, but if you have to at least treat it, is it the same if you can intervene with fluids, or is that different than if it requires pressors? If it requires pressors, then which pressor? Is there some pressors that are better for the heart or some pressors that are better for the brain than other pressors, or is it merely a blood pressure response to it? That remains unclear. Should I alter the anesthetic concentration and not use pressors? Does that make a difference, and how does that have implications here? So there's lots of work still to be done and lots of questions to be answered around hypertension that get us, after we agree that hypertension's bad, now how do we actually predict it? How do we prevent it? And what are those different strategies for different etiologies of hypertension? If you ask what we're presently doing, for most cases, we define normotension as trying to keep it within about 30% of baseline. If the blood pressure is low at baseline, then we tend to get narrower, tighter in our definition. We get even stricter if they have significant organ mouth comorbidities. And then we consider autoregulation. There's a variety of studies being done at several different centers in Chicago, in Baltimore, out west in Texas, and kids that are looking at not managing the patient's intra-op by their mean blood pressure or their systolic blood pressure, but by using cerebral blood flow monitors, calculating and demonstrating the autoregulation curve for the patient, and then managing them within the safe zone of their autoregulation and customizing that to individualized care. You're beginning to hear about that potential strategy also being tried in the ICU as well. So that may be the future. It may not hold up to be true. We don't know yet. So hypertension associated with badness, yes. If we diminish the hypertension, are things less bad? I showed you a little bit of data about that, yes. Do we know if it's an association or a causation? We don't know. There does seem to be some degree of dose response, so it looks a little more causal than just association. Can we predict when hypertension occurs? Not completely yet, but there are lots of people working on that ability to do that. There are studies looking at different drugs and then looking at different organ dysfunctions to try to help associate that. And then we still don't understand whether all causes of hypertension lead to the same outcome. So is it epidurally dosed hypertension? Is that the same as induction hypertension? Is that the same as hypertension 2 hours post-op? And so still more work to get done. I wanted to show you there's at least 4 publications just in the last sort of 12 months. This top one should say 2024, sorry about that. And then remember, when all else fails, just tell your patient, could you please stop having hypertension? That would be great.